Hello, my name is Dr. Kwong Wei Yan, consultant physician and nephrologist. Today, I'm going to share with you a very short presentation entitled Trembling with Parkinson's. Parkinson's basically means Parkinson disease. This is the outline of about Parkinson disease. Parkinson disease in the inpatient setting, be it in hospital or nursing home, and also end of life issue. As a lot of you may know, me and my partner, Dr. Lim Chin Sing, running our chains of nursing home, Elder Love Living Care and Rehabilitation Center. Essentially, we are seeing a lot of our patients at the nursing home setting are having this disease, Parkinson disease, in addition to dementia. So this is a very common disorder, unfortunately. A lot of our patients have it. Just a little bit of introduction about Parkinson disease. Parkinson disease is the second most common neurodegenerative condition after Alzheimer's disease. As the name implies, neurodegenerative condition means that medical condition that causes degenerative changes of the brain and also the nervous system, the neurological system. If we dissect or if we perform autopsy on patients who die from Parkinson disease, you'll see some classic changes in their brain, and we call it the Lewy body inclusions, accumulation in the brainstem, substantia nigra, and also the cortex of the brain. These three areas basically. I don't have the numbers of Parkinson disease in Malaysia, but look at the number I provide you here, which is the prevalence and incidence of Parkinson disease in the United Kingdom. Prevalence means there are how many population currently with Parkinson disease. Incident is the newly diagnosed case per year. In UK, has been recorded that the incidence of Parkinson disease is about 13 per 100,000 per year. But of course, this percentage usually rises with when the patient is getting older. More statistic here, 2% of those over 80 years old have Parkinson disease, and up to 10% of people in nursing homes. Although these are UK statistics, but I'm not surprised because as I mentioned, me and my partner, Dr. Lim Chin Sing, are running nursing home, and we frequently see some of the elderly patients coming into our nursing home for care are basically having this medical condition. Diagnosis of Parkinson disease. So why do we call it Parkinson disease? Disease has been prescribed throughout history. Before Dr. James Parkinson first described the cardinal features in 1817, which is more than 200 years ago, of course, Parkinson disease has already been there for hundreds, if not thousands of years. We call it the shaky palsy before Dr. Parkinson described it. Dr. James Parkinson was the first physician who described this condition in a clearer manner. He described this condition as having a few cardinal features, namely tremor, bradykinesia, meaning that the movement is slow, stiffness, and also postural instability. Postural instability means that the patient is unstable, especially when they are change their posture. The diagnosis of Parkinson disease remains essentially a clinical diagnosis, meaning that there's really no blood test, no urine test, no imaging, X-ray or ultrasound or CT scan or MRI that can confirm the diagnosis. And we can only diagnose this condition via clinical diagnosis, meaning that we try to observe the patient's signs and symptoms and we make the diagnosis depend on the patient's signs and symptoms. Patients usually present in a very heterogeneous manner. But as Dr. James Parkinson described more than 200 years ago, there are a few cardinal features which are very, very classic for Parkinson disease. Number one is tremor. Usually, the tremor in Parkinson disease would not be like the shakiness when we are getting nervous, or the shakiness of the hand, fine tremors when a patient is having a thyroid problem. The tremor in Parkinson disease is very, very classic. We call it pill rolling tremor. So just imagine holding a pill, a round pill medication between your thumb and also the index finger, and then you just roll the pill. And actually the tremor in Parkinson disease patients are basically pill rolling tremor. When you look at the tremor, it seems like they are really rolling the pill, but of course there's no pill in their hands. or between their fingers. Number two is gait problems. One of the very classic one is called shuffling gait. Remember when you're playing cards, during New Year's Day or something like that, during Chinese New Year, you play your cards with your friends and relatives, right? And you shuffle the cards before you distribute the cards. So the act of shuffle, remember the act of shuffle. Basically, just imagine that, and then the Parkinson patient will be having a gait as if they are shuffling. If my description is not clear enough, you can simply, Google pill rolling tremor and shuffling gait in Parkinson diseases, and you'll see what I mean. Number three is, of course, falls. Yeah, just because the patient's bradycardia, postural instability, they tend to fall. And of course, the next one is stiffness or slowness. Sometimes we describe them as freezing. Another few classic movements of Parkinson disease patients are when they are getting ready to move, they are very slow, very stiff or very slow. But once they have already kick-started in walking, once they have already, moving, when you ask them to stop, it's very, very difficult to make them stop. So all of this contributed to the fact that they can fall very easily. How about non-motor manifestation of Parkinson disease? As I mentioned just now, Parkinson disease have a few cardinal features, but these are the non-motor manifestation. Depression can happen up to 60% of Parkinson disease. Dementia, up to 75% of all patients with Parkinson disease. Sleep disturbances, GI disturbances, restless leg syndrome, pain, urinary problem, or postural hypotension. Of course, I'm not trying to scare you. If you have some of these symptoms and these conditions are so common. If you have one or two of these conditions, doesn't mean that you have Parkinson disease. Yeah. So, if you're in doubt, regarding these symptoms that you or your loved one experience, just try to, bring you yourself and your loved one to see a specialist doctor, preferably a neurologist or physician at least. Drug therapies for Parkinson disease. Of course, Parkinson disease, unfortunately, is a progressive disorder. But before they progress to end stage, if we try to use some medication to control their manifestation, control their motor or non-motor manifestation, their symptoms might be relatively well controlled for a number of years. Standard drug therapies, I'm not going to go through all of these, but just ask your doctors, your physician, or your neurologist, and they'll describe to you how these medications are working, what should be the doses, and what are the side effects, and so on. I'm going to talk a little bit about Parkinson diseases in the inpatient setting, because these are the condition that we see day in and day out. When we are practicing in hospital, or when we are seeing our patients in our nursing home, we do see a lot of Parkinson disease people. And sometimes doctors like us need to be well equipped with knowledge about how to take care of Parkinson disease patients in the inpatient setting. So why do patients with Parkinson disease get admitted? Of course, it can be elective admission. For example, they need surgery. Of course, they need to be admitted, right? So it could be something totally not related to their Parkinson disease. But majority of them, they need admission because of emergency admission, can be due to their Parkinson disease, can be related to the comorbid condition, comorbidities, acute or chronic comorbidities. And also, especially we are seeing this a lot in nursing home, is failure of social care. So after a patient has been diagnosed with Parkinson's disease for multiple years, despite their response well to some medication initially, it's a very sad and unavoidable fact that their disease will progress. Once their disease get progression, then they have got a lot of issues one by one. Starting with frequent falls, and then just because they are not able to clear their secretion when they are a few years down the road, then they might be getting repeated admission for pneumonia and so on. And at the very end stage, some of these Parkinson diseases, patients might not even be able to swallow, because like I mentioned, it's neurodegenerative disorder. So when they are not able to swallow, you need to make the decision whether or not they need to be fed via an NG tube, which is a tube that you insert via the nose. So all these are the things that can happen in Parkinson disease patient when their condition, get worse. Their family members might not be able to take care of them anymore because it's really, really not easy to take care of advanced Parkinson disease patients. So general advice, this might not be relevant to you all, but it's very relevant to myself as a reminder, and also for my juniors, all the junior doctors who will be involved in the care of Parkinson patient one way or the other. So check what drugs they take and prescribe them at the correct time. Never ever give antiemetic medication called Maxilon. Antiemetic means a medication to prevent vomiting. So not only we need to know that, our surgical colleagues need to know that, just in case the patient is coming in for some elective surgery, and of course because of the pain and nausea after surgery, they might be given some medication to reduce the nausea feeling. And then if you are giving Maxilon to this patient, they would have a lot of side effect. Another one is called Stametil, which is a no-no as well. There are a few other medications that are relatively or absolutely contraindicated in the setting of Parkinson disease. Another one is domperidone, and the fourth one is cyclizine. All these are medications that are no-no. We shouldn't be giving this to the patient if you want to avoid any trouble. And also never give any antipsychotic medication, meaning any medication for anxiety, severe depression, or severe psychosis, except quetiapine. Quetiapine is safe for Parkinson disease people. Some of these medications are not safe, mainly because of the interaction between this medication and the patient's pre-existing medication that treat their Parkinson disease. Another one is, of course, falls. As I mentioned, one of the features for patients with Parkinson disease would be frequent falls. They don't want it, they don't want to fall down as well, but unfortunately, because of their bradykinesia, because of their gait disturbances, because of their tremor, they can fall down very, very easily. It can be caused by many factors. It can be caused by under treatment of Parkinson disease, meaning that when they have Parkinson disease, but they did not bring the patient to see doctors, or they brought the patient to see an inexperienced doctor who doesn't have much experience to treat Parkinson disease. So it can be assessed by the degree of rigidity and also bradykinesia. Rigidity means that the patient's body is very rigid. Sometimes they can even have what we call cogwheel rigidity. So all these terms, you can basically Google them to look at the videos. However, on the other hand, it can be due to overtreatment, because when we overtreat a patient with Parkinson disease, their movement might be better, not that slow anymore, but they can actually move very erratically. And this can cause their increased chance of falling down as well. As I mentioned to you before, some of the non-motor presentation or manifestation of Parkinson disease can also include postural hypotension. It means that the patient's blood pressure is fine when they're sitting down, but when they move up, when they get from sitting to standing position, they can have their blood pressure can drop. So this is what we call postural hypotension. And sometimes, when a patient is having advanced Parkinson disease, this might happen, and you should consider to stop or at least to slow down some of their medication for blood pressure. And also, falls can be related to late stage diseases. When a patient is having Parkinson, for example, a few years, 10 years, and their disease are so advanced until they cannot be responding to medications anymore. So of course, when that happens, they're prone to falling down. They can have multiple complications. For example, unable to swallow. When they swallow, they get aspirated into the windpipe and cause pneumonia and whatnot. So if we are at that stage already, sometimes we really need to discuss end of life care with the patient and the family, especially the family. Cognitive decline, as mentioned just now, very, very common. So dementia can occurs up to 75% of people with Parkinson's disease, manifest with confusion, fluctuation of their mentation, and visual hallucination. They see things that are not there. Drugs is very ironic, because drugs which help with the movement can exacerbate cognitive decline. So it's a very, very hard, balance that we should try to find. For example, if we don't use some medication to control their movement, they might be prone to fall and whatnot. But if we use this medication, then it might actually exacerbate the cognitive decline. So again, this is a very thin line that we need to, walk on. Concurrent illness unmasks underlying cognitive vulnerabilities. What to do with acutely confused PD patient? This is a challenge. If you're in doubt, don't do it. Refer the patient to people who are more experienced. For example, physician like myself or my physician colleagues who are specialized in neurological conditions. We call neurologists. So those are the people who are really, really specialized in handling Parkinson disease patients. We need to exclude and treat concurrent illness. As I mentioned just now, whether or not the patient is having Parkinson disease, but when they come in with infection, for example, people might get confused. So not to mention Parkinson disease patients, when they have already advanced Parkinson disease, when they come in to the hospital with concurrent illness, for example, severe infection, of course, their Parkinson disease would get worse. Consider quetiapine is if extreme behavior or cutting down drugs which are not working. Do not use any other antipsychotic, as I mentioned just now, beside quetiapine. We can safely use lorazepam or ativan for as needed basis in a small doses. Benzodiazepine or lorazepam or ativan are basically medications to calm a patient down and for sleeping purposes. Is one of the types of sleeping pill, and in low doses, medication like lorazepam should be fine in addition to the quetiapine, which I just mentioned. Admission with other health condition. Parkinson disease will always be worse if there's another concurrent illness, as I mentioned just now. If a patient is having concurrent illness that make their condition worse, but their Parkinson disease is stable, might not be the best time to change around their medication if the patient has had regular outpatient review by specialists. And we should warn patient and the family member that recovery is long and Parkinson disease can take many weeks to return to baseline if they have got concurrent illness. It's a very unfortunate fact that Parkinson disease patients will progress after a few years. Just like all of us would get old. It's unavoidable or inevitable fact. It's just a way of life. Same with Parkinson disease patients. After a few years of having Parkinson disease, even though initially they are responding to treatment, it might not be so after a few years. You see that no matter how the specialists are adjusting the medication, they would not see improvement anymore. And in fact, they are getting worse and worse. For example, they can have more frequent fall. For example, they can have more frequent admission because of various factors. When they try to eat, the appetite is getting worse. And then when you try to feed them, maybe they are not able to eat by themselves anymore. When you try to feed them, they choke easily and then cause pneumonia and whatnot. So if the patients are having a host of this condition that I just mentioned, it might not be unreasonable to discuss what we call end-of-life issues. Death is inevitable for everyone, especially for advanced Parkinson disease patients. So it might not be unreasonable to initiate this kind of discussion earlier. But of course, these are very sensitive issues. If we want to discuss issues like this, we want to make sure that everybody is on the same page, including the family, patient, if they are still mentally sound, and also the treating doctors. Do not leave any loose ends. When we discuss this kind of thing, as I mentioned, we need to make sure everybody is on the same page to avoid any misunderstanding. When possible, we should discuss this with the patient and the family members, especially their close family members, their next of kin. If patient is admitted with any medical problem, when we are planning for discharge, we should consider advanced planning, especially when the patient is getting admitted more and more frequently. We should involve patients and their relatives, especially their close family members or preferably the next of kin, and make sure if the patient is a nursing home patient coming admitted to the hospital, if we have made any advanced planning, we should definitely notify the nursing. Parkinson disease specific end-of-life issues. There are a few issues. Maybe I've already mentioned the NG feeding. NG means nasogastric feeding. It means that if the patient is not able to swallow or they frequently choke on their food or drinks, at the time, we need to put a tube via the nose and then all the way thread to the mouth and thread to the food pipe, esophagus, and insert inside the gastric area, which is the stomach. This is one of the few ways to prevent patients from choking from their food and drinks. It's very complex in Parkinson's disease, and fortunately, not all Parkinson's disease patients need that. For example, patient in early Parkinson's disease, they would not need that. But I'm talking about patient with advanced disease. A loss of swallowing capacity or capability is usually an end-stage development. If you have noticed this, or if the caregiver have noticed the patient always cough upon feeding, always have a multiple admission for pneumonia, then we should think about this. So the family and the patient and the doctor should sit together and discuss whether they want to initiate NG feeding or what are the alternatives. So another thing is DNI, DNR. It stands for do not intubate and do not resuscitate. Again, this is a very sensitive issue, and then we should try our very best to make it clear to patients and the family. Sometimes, people with advanced diseases, like for example, advanced cancer, advanced heart failure, advanced kidney failure, patients who choose not for dialysis. It is really no point to do resuscitation or intubation when they collapse. Yeah, because the outcome is imminent. The death is imminent in this kind of condition. Not like younger people, for example, they get into trouble in very severe motor vehicle accident and collapse. Younger people who doesn't have any other medical condition and they are having a heart arrest, cardiac arrest. These are different scenario. In this kind of condition, we should of course do our best to revive the patient by doing resuscitation, meaning CPR and also intubation. But it might be a totally different scenario with advanced Parkinson disease patient. As a fact that if you are going to try to revive them by doing resuscitation, CPR, medication, intubation, the outcome will be the same. You might only prolong suffering. So these are the things that you need to discuss, with the patient and also the family, being a treating doctor. Antibiotics and repeat admission should be assessed and discussed, as I mentioned. And also, try to respect the family and the patient regarding the preferred place of death if you think that death is imminent. So I think these are all the slides I have at the moment. Thank you for your attention.